Welcome to Lesson 6. This is our final lesson in the Pharmacology Made Simple course, and we are focusing on cannabis and hallucinogens, including several substances that are commonly misunderstood or minimized or just described in overly simplified ways. And this lesson is going to matter because a lot of clients don't view cannabis as a serious substance. And a lot of people have very mixed beliefs about hallucinogens. They see them as harmless, they're natural, they're spiritual, and they're not addictive. And then others think of them only in the extreme or the outdated stereotypes. So, as counselors, we need to move beyond both minimization and exaggeration and look at these substances through a clinically useful lens. Because cannabis is really important because it is so common and it is so normalized and people defend it so much. And a client may fully acknowledge problems that are related to alcohol or opioids, and they still insist that cannabis is not part of the issue. Hallucinogens are going to create a different challenge. They may not be used as frequently by every client population, but when they do come up, they can involve intense perceptual changes. Maybe they're having panic reactions or doing dangerous behaviors. They may be disassociating. And in some cases, it has lasting effects that the client doesn't fully understand. So in this lesson, we're going to look at how those substances affect the brain, how they affect mood, how they affect the person's perception and their memory, how it's affecting their behavior, and what that means for assessment and counseling. And we're going to also address some newer issues like Delta 8 and Delta 10 and other hemp-derived THC products. We're also going to look at some synthetic cannabinoids. And you specifically wanted this lesson because it is a part of our day-to-day dealings with our clients in our sessions. And also we're going to talk about LSD. LSD, there's a lot of questions on the CAC test about LSD and certain hallucinogens, and they're going to ask about the symptoms, the effects, and so we're going to go into all of those things. So cannabis and hallucinogens differ from other substance categories in a couple of different ways. So alcohol and opioids, they're often easier for people to identify as being impairing substances because their effects are more familiar. They're more widely recognized. Cannabis and hallucinogens, on the other hand, are often talked about in ways that blur the line between the drug's effect and their personal experience. Because a lot of people describe them in emotional or spiritual or philosophical terms instead of clinical ones. And that makes it harder to really assess clearly if you're not careful. These substances often affect the person's perception, meaning the way that the person is experiencing time or space or emotion or energy. Their sensory input may be altered. And that creates a very different presentation than substances that mainly sedate or stimulate. So a client may not appear obviously intoxicated in the same way that somebody who is drunk or nodding off appears, but they may still be significantly impaired in judgment or concentration, emotional regulation, or a sense of reality. And then another challenge is minimization. Cannabis is often described as harmless because it's legal in some places. It's used medicinally in other places. And it's also been culturally normalized in a lot of groups. And hallucinogens can be described as like mind expanding or natural or spiritual. And that can make clients less likely to recognize the risks. And then at the same time, the actual substances in this category are going to vary a lot. Cannabis is not LSD. LSD is not PCP. PCP is not ketamine. And they may all affect perception in some way, but the pharmacology and the risks are not identical. So, as counselors, we have to separate the popular narratives from the clinical understanding. And that means we need to stay curious. We need to ask the specific questions and really focus on the effect and the pattern and the impact rather than the assumptions or the stereotypes. Because this approach is going to help you work more effectively with your clients who are using those substances. So, cannabis is one of the most commonly used psychoactive substances, and it's also one that is the most frequently minimized. And the primary psychoactive compound that most people think about is THC. That's what's producing the high that's associated with cannabis use. THC is going to affect multiple areas of functioning, including the person's mood, their memory, their attention, their reaction time, and also their perception. And depending on the dose or the potency or the route of administration or how individually vulnerable this person is, the effects are going to range. And it could be something like mild relaxation to really significant impairment and having anxiety and paranoia and confusion. And one of the reasons that cannabis is really tricky in counseling is that the clients are often comparing it favorably to other substances. So they're going to say things like, at least I'm not drinking, or, oh, it just helps me relax, or, oh, it's natural, it's just a plant. And those statements may reflect part of their experience, but they're not erasing the actual effects of the drug. Cannabis can impair your short-term memory. It does reduce your concentration. It slows your reaction time and it affects your motivation. And in some clients, it's also going to increase their anxiety. It's going to worsen their panic symptoms. It's going to contribute to the psychotic experiences. And another important point here is that modern cannabis is not always comparable to the lower potency products that people may remember from several years ago. The potency has increased substantially in a lot of products, especially the concentrates and the edible products. And that changes the risk profile and the intensity of the effects. So the clients underestimate edibles because the onset is delayed, and that leads them to take more than the first dose before it's fully taken effect. And as a counselor, it's really important to assess cannabis with the same seriousness that you would assess any other psychoactive substance. And that doesn't mean that we treat every use pattern as identical. But it does mean refusing to let social norms replace clinical observations. If the substance is affecting the client's mood, if it's affecting the client's memory or their functioning or their treatment progress, then it matters. So, cannabis affects the brain through the endocannabinoid system. And that plays a role in mood, memory, appetite, stress response, and other regulatory functions. THC is going to act, it's interacting with this system in a way that's altering normal signaling. That's why cannabis can affect such a wide range of experiences from, relaxation and appetite to memory disruption and altered perceptions. And one of the most notable effects is on their short-term memory and attention. The clients may have trouble focusing, recalling what was just said, or tracking their thoughts clearly when they use cannabis. And that affects their work, their school, their parenting, their driving, their engagement in the counseling process. And cannabis can also affect their coordination and their reaction time. And that's one reason it impairs driving, even when the person insists that they're feeling fine. The mood effects are going to vary. Some clients are going to feel relaxed and calmer. Others are going to become anxious or suspicious. They may even get self-conscious or emotionally dysregulated. And in some people, especially at higher doses or with high potency products, the cannabis is going to contribute to panic, derealization, or psychotic-like symptoms. And this variability is one reason it's not enough to assume cannabis is affecting everybody the same way. So as a counselor, understanding the endocannabinoid system at a basic level is going to help you explain why cannabis is not something that just chills people out. It's affecting their brain systems that are involved with their memory, their attention, their emotion, and their perception. And that's going to make it clinically relevant even when clients try to frame it as something that's harmless. So before I go any further into cannabis, I want you to understand the endocannabinoid system, because this is the system where cannabis is acting on in the body. So the endocannabinoid system is just this broad signaling network that's helping regulate balance across multiple body functions. So it's playing a role in their mood, their memory, their appetite, their pain, their stress response, inflammation, and all types of other areas of functioning. So in other words, this system is not just limited to one part of the brain or one single body process. It is spread broadly throughout the body, which helps explain why cannabis can affect so many different experiences at once. The body naturally makes its own endocannabinoids, and two of the most commonly discussed are anandamides and 2-AG, and that stands for this is such a hard word to say, arachidonyl glycerol. And these are naturally occurring chemical messengers that help the body communicate within that system. So anandamides, they're sometimes informally called the bliss molecule because of its connection to mood and emotional tone. And although that nickname kind of oversimplifies what it does, 2-AG is another major endocannabinoid, and it's generally present in higher amounts in the body. And together, these messengers are helping to regulate signaling in ways that are supporting stability and balance. And these natural endocannabinoids, anandamides and 2-AG, they're going to interact with two different types of receptors, the CB1 receptors and the CB2 receptors. CB1 receptors are especially concentrated in the brain and the central nervous system, but they're not limited to those areas. And they're strongly involved with the person's memory, their coordination, reward, mood, and perception. And this is one reason that THC has such a noticeable psychoactive effect. Then we have the CB2 receptor sites, and these are also found throughout the body. And they're often discussed in relation to immune functioning, inflammation, and peripheral systems. But it's important to say clearly that we haven't done much research on CB1. There's no more on CB1 than CB2. And CB2 receptor functioning is not really fully understood. We know CB2 receptors matter, but there's still more to learn about exactly how it affects the body in different contexts. But one important counseling takeaway is that cannabis doesn't just go to the brain. It affects a system that has receptor sites across the body. And that's going to help explain why cannabis influences not only the mood and perception, but also their appetite, their pain, their inflammation, their physical sensations, their stress responses, their sleep, their dreams, because it's affecting the, not the pituitary gland, the pineal gland, which also produces melatonin and DMT. And when they come off of it, when we talk about withdrawal from this, it's affecting them by, they can't sleep, and now they're having wild dreams because the body's like swinging the opposite way. So there's a lot going on here. And as counselors, we don't need to teach this like a neuroscience lecture, but understanding the endocannabinoid system is going to help you explain cannabis more accurately. And it's going to help the clients understand that cannabis is not just creating a vague high, it's interacting with a real whole body-wide regulatory system that's affecting multiple areas of functioning. That's what makes it clinically relevant, even when your client is trying to minimize it. So in the short term, cannabis produces a range of effects that clients often describe as positive or neutral or mixed. Some people feel relaxed, lighter, more amused. Other people feel introspective and more sensitive to the sensory experiences. time feels slowed down. Ordinary events may seem more intense or more interesting. And these effects are part of what makes cannabis appealing to a lot of users. And then at the same time, there's some meaningful impairments happening. Their memory is going to be affected, their short-term recall especially, their attention may become more fragmented, their coordination and reaction time is going to be reduced, their judgment's going to be altered in subtle ways, meaning that the person can underestimate how impaired that they actually are. And all of this is part of why cannabis can affect tasks like driving or working or caring for children or following through on their responsibilities, even if the person is insisting that they're functioning normally. Their appetite often increases, which some clients may see as helpful, others don't, especially if they're trying to lose weight. Mood effects also vary widely. Some people are calmer, others are more anxious and paranoid. And this variability should always be part of the assessment. Don't assume that the client experiences cannabis the way other people do. And as a counselor, short-term effects are going to matter because they're influencing both their behavior and their insight. So a client who uses daily may not notice some of these effects clearly anymore, especially if tolerance has developed. But that doesn't mean that the effects are not there. It means that you may need to ask more specific questions to help the client look at the real impact. Long-term cannabis use doesn't always affect everybody the same way either, but there are several patterns that counselors should know well. And we know that some clients report reduced motivation, so we call it an amotivational drug. They have lower follow-through, just a general sense of emotional flattening over time. Others are going to experience persistent problems with concentration or memory or organization, especially with heavy or frequent use. And these issues can interfere with work, school, relationships, and also with the treatment participation. And the use of cannabis is also going to increase anxiety over time in some people, even if it initially seemed to reduce the anxiety. So a client may start using it to relax, and then later they find out that it contributes to their panic or their overthinking or their social anxiety or just their general dysregulation. And that creates this confusing loop where the substance is both the perceived solution and part of the problem. And another important issue is the psychosis risk. Cannabis doesn't cause psychosis in everyone, but in vulnerable individuals, especially with high potency use, it increases the likelihood of psychotic symptoms or worsening any existing vulnerability. And this is especially important when there's a personal or family history of psychosis or severe mental illness. So as counselors, we don't need to take an extreme position to take cannabis seriously. We just simply need to assess honestly. If long-term use is affecting their mood or their motivation, their memory, or their mental stability, then it's clinically relevant. And that's the standard to use. I do want to make sure I covered this. I didn't cover it with the other lessons, but this is really important because it doesn't have like when the baby's born type of effect. This is like years down the road. Cannabis use during pregnancy is often misunderstood, it's minimized, and it's surrounded by mixed messages. And that makes it really important for us to understand it clearly. We all know about fetal alcohol syndrome, right? We all know about what they call quote unquote crack babies, the children born to those addicted to crack or those addicted to heroin. We know the long-term effects of those, but there's a lot of questions about what happens and a lot of women who use THC while they're pregnant thinking that it's safe. But THC, which is the primary psychoactive compound in cannabis, is able to cross into the placenta. And so that means that when the pregnant individual uses cannabis, the developing fetus is directly exposed to the THC. And this is not an indirect effect. It is a direct interaction with the fetal system. And that matters because the fetus has a developing endocannabinoid system. And that's going to play a role in that person's brain development, their neural signaling, and their overall regulation. And when external cannabinoids like THC are introduced during this critical development period, they can disrupt normal signaling processes. The system still forms, which means that it may be more sensitive to disruption than a fully developed adult system. And the research has suggested the links between prenatal cannabis exposure and later neurodevelopmental concerns, like differences in attention or behavior, impulse control, or emotional regulation. And some studies also suggest an increased likelihood of learning difficulties or developmental delays. The outcomes are varying, and they're influenced by multiple factors. And that's not saying that every child exposed is going to have problems, but it is recognized as an increased risk. And there's also a concern about the potential connection between prenatal cannabis exposure and an increased risk of sudden infant death syndrome. And while the research is ongoing and complex, the presence of this association is clinically important enough that we shouldn't dismiss it. Even the possibility of an increased risk is such a serious outcome, it should be part of how we're approaching education. And one of the biggest challenges in this area is that cannabis is often framed as natural. And that leads people to think that it's safe during pregnancy. Some even use it to manage their nausea or their anxiety or sleep issues while they're pregnant. So as counselors, we're not here to shame them or judge them, but we are responsible for providing accurate information. Natural doesn't necessarily mean risk-free, especially during fetal development. And when we work with clients, this topic should be approached with sensitivity, but also with clarity. The goal is not to create fear, but to support informed decision-making. Understanding how cannabis is interacting with the developing endocannabinoid system is going to give you a stronger, more accurate way to explain why this matters. Adolescent and young adult cannabis use is another critical area that we need to understand, especially because this is often when the use begins and when it becomes more frequent. And the general risk window that is most often discussed is approximately the ages between 14 to 24. And that corresponds to a period of ongoing brain development. So during this time, the brain is still refining connections, especially in the areas that are related to decision making and impulse control and emotional regulation, and also executive functioning. So when the cannabis is introduced during this developmental period, it's interacting with a brain that's still forming. And that affects how the neural pathways are developing and stabilizing. And not every adolescent who uses cannabis is going to experience severe consequences. There is strong evidence that early and frequent use increases certain risks, particularly in vulnerable individuals. And one of the most serious concerns is the increase of risk of psychosis and schizophrenia spectrum disorders. Cannabis use doesn't, create schizophrenia out of nowhere in every case, but it can trigger an earlier onset or unmask an underlying vulnerability in people who already are at risk. And that means that, somebody who, they may develop symptoms later on in life or possibly never at all, and they may begin experiencing them sooner or more intensely with the cannabis use. And this risk appears to be higher in males, although it's not exclusive to males. So the reasons for this, we're still studying them, but the pattern is consistent enough that it's important to highlight. Family history is also going to play a major role. If a client has a family history of schizophrenia or other psychotic disorders, the cannabis use during adolescence is going to become even more of a significant concern. And our clients, especially the younger clients, are often going to minimize their cannabis use because it's common among their peers. They see it as a normal part of social life or a normal part of their identity. And they also believe that because other people use it without any obvious consequences, that it must be safe. And this is where individualized risk becomes important. Not everybody has the same vulnerability, and not everyone is going to respond the same way. And not everyone's going to show symptoms immediately. So as a counselor, your role is to assess the risk, not assume it. Ask about age of first use. Ask about frequency. Ask about potency. Any experiences of paranoia, unusual thinking, or perceptual changes. If a client reports symptoms that could indicate early psychosis, that should be taken seriously and may require a referral. This topic's important because the consequences can be long-term and life-altering. So I want to make sure that you have clear and accurate information about the adolescent brain development and the cannabis-related risk. When they have that information, they're able to make some more informed decisions. And it's going to help you identify when what looks like just weed may actually be something a little bit more serious. Another important modern issue in cannabis work is the rise of hemp-derived THC products like Delta 8 and Delta 10. These products became widely available in places because of a legal loophole that related to hemp definitions. And a lot of consumers interpreted that availability as proof that the products were safe or insignificant. But in reality, these substances are still psychoactive and they can still impair functioning. They're affecting the people's moods and they are creating problems that are very similar to other cannabis products. And the clients often minimize these products because they're sold openly in gas stations. You can get them in vape shops or online. And they say, oh, it's not real weed, or I got it legally, so it's different. But from a counseling standpoint, the important question is still, how does it affect you? Does it alter your mood or your memory, your judgment, your behavior, or how you're functioning in treatment? And if so, then it matters. And then another concern is inconsistency. The potency, the label accuracy, the additives, the manufacturing quality, all of it varies from brand to brand and from product to product, even within the same brand. And that means the client doesn't really fully know what they're taking or how strong it is. Some products may produce stronger effects than expected, like anxiety or sedation or paranoia or disassociation. And this is also where the place where it's going to make sense to include a legal disclaimer. So you need to understand that the 2018 federal hemp framework created space for a lot of these products to enter the retail market. But recently, in 2026, there was federal legislative changes that were passed to close that loophole. With they're implementing effective the products like Delta 8 and Delta 10. So they're going to take those off starting in November of 2026. The key counseling point here is not to give legal advice. I just want to help you understand why clients may wrongly equate retail availability with safety. Synthetic cannabinoids, these are often sold under names like K2 or Spice. They're not the same as cannabis, even though they're marketed that way. And these substances are laboratory-made chemicals that are designed to act on the endocannabinoid receptors, but they do it in a way that's way more intense and unpredictable. And so as a result, their effects are much more severe than the natural cannabis. So clients think that they're using a fake weed product that's basically similar to cannabis, and that assumption is dangerous. Synthetic cannabinoids have been associated with extreme anxiety, agitation, psychosis, hallucinations, cardiovascular problems, and severe medical emergencies. And the presentation can look more volatile and dangerous than just the typical cannabis presentation. And then another major problem is unpredictability. The actual chemical composition may vary widely across products and even across batches. And the client may have no reliable idea of what they're using or how their body's going to react to it. And that creates a significant risk for both acute crisis and poor clinical understanding. So as a counselor, don't let the word cannabinoid make these products seem lower risk than what they actually are. Synthetic cannabinoids deserve their own careful assessment and their own risk attention. If a client's reporting using K2 or spice, that needs to increase your concern, not reduce it. Hallucinogens, these are a category of substances that primarily affect perception, mood, and thinking. So, unlike the depressants, which are slowing things down, or the stimulants, which are speeding things up, hallucinogens just change how a person experiences reality altogether. And that includes visual distortions, an altered sense of time, emotional intensity, and also changes in how thoughts are processed. So it's important to understand that hallucinogen is just a broad category. And not all substances in this group are going to work the same way. So we have some like LSD and psilocybin mushrooms. These are referred to as the classic hallucinogens, and they're primarily affecting the serotonin systems. And then we have others like PCP and ketamine, and these are better classified as dissociatives, or the synthetic dissociatives, because they're affecting the different systems in the brain. But from a counseling perspective, we group them all together because they all alter perception in very significant ways. And the clients often describe these experiences in subjective or emotional language. So they say things like, oh, I had a spiritual experience, or I saw things differently, or it changed how I think. And those descriptions are real experiences, but they don't replace the need to assess risk and impairment. A substance can feel meaningful and still be clinically significant. And hallucinogens can produce both positive and negative experiences. You know, some people report insight or emotional release. Others are going to experience panic and confusion or fear. And the same substance can produce very different effects depending on the person, the dose, the setting, and their mental history. So as a counselor, your job is to look beyond the narrative and understand what's actually happening in the brain and their behavior. That's going to allow you to assess risk and respond appropriately and avoid either dismissing or over-romanticizing the experience. Now, LSD is one of the most well-known hallucinogens, and it's important to understand both clinically and for exam prep. It is a very potent substance, meaning that even small amounts produce really strong effects. And LSD primarily affects serotonin systems in the brain. Particularly, it's affecting the receptors that are involved in perception and mood regulation. And one of the defining features of LSD is its duration. The effects can last anywhere from 8 to 12 hours or longer. And that means that the person is in an altered state for an extended period of time. And that's very different from the substances that wear off way more quickly. And once the experience begins, it cannot be easily stopped, which can increase the risk if the experience becomes negative. So we know LSD produces visual distortions, changes in color and light perception, an altered sense of time, shifts in emotional experiences. Some users report feeling connected, insightful, and deeply reflective. Others experience intense anxiety and panic and confusion, or maybe they're experiencing fear. And these negative experiences are often referred to as bad trips. But that term can minimize how severe they actually feel in the moment. And so from a counseling perspective, LSD matters because of its intensity and its unpredictability. The client may have used it only a few times, but still had very significant psychological experiences. And these experiences can influence their mood and their thinking patterns and even ongoing anxiety after the substance has worn off. And it's also important to recognize that LSD is specifically included in many certification exams, including the CAC-1 exam. So you should be able to identify it as a hallucinogen, understand its duration, and recognize the potential psychological effects. Now, psilocybin is the active compound found in certain types of mushrooms. People often refer to this as like magic mushrooms, and it's like LSD. It's primarily affecting the serotonin receptors, and it's altering perception and mood and thinking. And the experience may include visual changes, emotional shifts, and an altered sense of time. And one of the key differences from LSD is that psilocybin is often described as more natural, and that leads the client to assume that it's safer. But the source being natural doesn't eliminate the risk. Psilocybin can still produce intense psychological effects, like panic and fear and confusion and just distressing experiences. And some users describe psilocybin experiences as meaningful or spiritual. And while, yeah, that may be part of their experience, it's still important to assess the impact. Did the use lead to confusion or risky behavior or emotional instability, or did it change their functioning? Those are the clinical questions that are going to matter. So it's important to distinguish between the classic hallucinogens like LSD and psilocybin and the dissociative substances like PCP and ketamine. Both are going to alter perception, and they do it through different mechanisms, and they're often producing different types of experiences. So dissociatives, they tend to create a sense of detachment from reality. The clients may feel disconnected from their body. They feel disconnected from their surroundings. They don't really fully feel present or fully real. And from a behavioral standpoint, dissociatives can be more impairing and unpredictable. They're associated with confusion and disorientation and impaired motor control, and in some cases, aggressive or erratic behavior. And that's especially true with substances like PCP. And understanding this distinction is going to help you assess risk more accurately. Not all hallucinogens are going to carry the same type of risk, and recognizing the difference is going to help guide your response. So PCP is a dissociative substance, and it produces some really intense and unpredictable effects. And so it's going to affect multiple neurotransmitter systems, and it significantly impairs perception and judgment and awareness. So clients under the influence of PCP may appear confused or disoriented, or they're just disconnected from reality. And one of the most concerning aspects of PCP is its association with aggressive or erratic behavior. And that doesn't happen in every case, but it is a known risk. And the combination of impaired awareness and altered perception leads to dangerous situations for both the individual and for other people. So PCP is going to reduce sensitivity to pain, and that's going to contribute to risky behavior. So a person may not respond to injury or danger in a typical way, and that increases overall risk. I don't know if y'all remember, like, the guy that got shot by the police officers and he just kept coming at them. So as a counselor, PCP use should always be taken seriously. It's not a mild or low risk substance. If a client reports PCP use, that should increase your level of concern and prompt careful assessment. Now, ketamine, this is another dissociative substance that occupies a very unique position because it exists both in the medical and the recreational context. So it's in the controlled medical settings, ketamine's used more as like an anesthetic. And more recently, in specific mental health treatments like treatment-resistant depression, they're using it under strict supervision in like microdosing and talk therapy to deal with the depression. But outside of those controlled environments, ketamine can be misused in a lot of ways, and that creates significant clinical concerns. And from a pharmacological standpoint, ketamine affects the glutamate systems in the brain, particularly the NMDA receptors. And that's going to contribute to the dissociative effects that the person's going to experience. So rather than simply just altering their perception like the classic hallucinogens, ketamine tends to create a sense of detachment. And the clients describe feeling disconnected from their bodies. They feel disconnected from the environment or even their sense of identity. And this can range from mild disassociation to very intense experiences where the person is feeling like completely removed from reality. And at lower doses, the user feels relaxed, dreamy, slightly disconnected. And then at higher doses, they enter what's commonly referred to as a K-hole, which is a state of profound disassociation. And in this state, the person may have a very limited awareness of their surroundings. They're going to have impaired movement, muscle rigidity, and difficult time communicating. And that creates safety risks, especially if the person is in an uncontrolled environment. Memory impairment is another important factor. The clients may not fully remember what happened while they were under the influence, and that complicates assessment and it increases vulnerability. They may not recognize risky behavior, or maybe they're underestimating how impaired they were. And over time, repeated use is going to lead to patterns of psychological reliance, even if the person doesn't initially view ketamine as addictive. Another clinical issue is minimization due to medical framing. Clients are going to say things like, oh, they use it in therapy now, or it's used in hospitals. And that's just a way to downplay the risk. The statement is technically true, but it's ignoring the importance of dosage and setting and supervision and also intent. Medical use is controlled, it's monitored, it's structured. Recreational use is not. And so as a counselor, your role is to assess how the ketamine is being used, what impact is it having. We need to be asking about frequency, dose, context, what's the client's experience during and after the use, and if the disassociation is severe, or if the memory is impaired, or if the use is becoming repetitive, those are clinically significant concerns. And understanding ketamine is going to help you avoid both overreacting and underestimating. And it's going to allow you to respond with accuracy and appropriate concern. Now, I do want to talk about nitrous oxide. They call these whippets. This is a substance that's frequently underestimated because of how it's perceived culturally. And it's commonly associated with recreational or party settings. And a lot of people view it as it's harmless, it's insignificant. But from a clinical perspective, nitrous oxide, the use carries some real and sometimes serious risks that should not be ignored. Nitrous oxide is an inhalant that produces rapid onset effects, typically within seconds. And the users experience euphoria, lightheadedness, altered perception, and a sense of disassociation. The effects are short-lived. They only last for a few minutes. And because of this short duration, a lot of users engage in repeated dosing in a very short time period, and that significantly increases their risk. And one of the primary concerns with nitrous oxide is oxygen deprivation. When it's inhaled, the nitrous oxide displaces the oxygen, especially if it's used improperly or repeatedly without adequate air intake. And that can lead to dizziness and confusion and a loss of consciousness, and in severe cases, brain injury. And the risk is not always obvious to the user because the experience may feel very brief and manageable in the moment. And another important issue is that clients don't consider nitrous oxide to be drug use. So they may not report it unless you ask directly, or they may minimize it when they do. So, oh, it's just whippets. It's not like it's a real drug. That's good. You're going to hear that. And that creates a gap in assessment if the counselor's not specifically asking about inhalants or gas-based substances. And we know that repeated use leads to neurological concerns over time, particularly related to vitamin deficiencies and nerve functioning. And not every user is going to experience these issues, but the possibility is clinically relevant, especially with frequent use. And from a counseling perspective, the key is to recognize that short duration doesn't mean low risk. In fact, the short duration can lead to patterns of repeated use that are going to increase the overall exposure and danger. And so you need to assess frequency, context, how the substance is being used, and then you should also provide clear education about oxygen deprivation and cumulative risk. Nitrous oxide is a really good example of a substance that falls outside of what a lot of clients consider serious, but it still has meaningful clinical implications. So your awareness and your assessment are going to make all the difference in whether the risk is identified or it's missed. Um, Hallucinogen persisting perception disorder, or HPPD, is a condition that's involving ongoing or recurring perceptual disturbances after the use of the hallucinogen. And this is most commonly associated with LSD, but it can occur with other substances as well. So the key feature of HPPD is that the perceptual changes are going to continue after the drug has left the system. Clients may report visual disturbances like trail behinds, moving, like a trail that's behind a moving object, or maybe they see flashes of light or geometric patterns. Maybe they're starting to see halos around objects or distortions in color and depth. And these experiences can be mild and sometimes occasional, or they can be persistent and really distressing. And what makes HPPD clinically significant is that the person is no longer actively using the substance, but the effects are still happening. And the timing can vary. Some people experience symptoms shortly after their use, others notice them days or weeks or even months later. And this unpredictability can be really confusing and frightening for clients. They may not connect the symptoms to past substance use, or maybe they're worrying that they're losing their mind. And HPPD is often misunderstood or minimized, both by clients and sometimes by professionals who are not familiar with it. Some clients may refer to these experiences flashbacks, although that term can be really misleading. These are not full re-experiences of the original drug event, but rather persistent perceptual disturbances. And so from a counseling standpoint, it's important to take these reports seriously. Even if the symptoms are not constant, they can cause anxiety, distress, and functional impairment. And clients are going to become preoccupied with the experience of, or maybe they're fearful that it's going to get worse. And assessment really needs to include questions about past hallucinogen use, the timing of symptoms, the frequency, the impact on functioning, and referral it might be appropriate here if the symptoms are severe or persistent. And again, your role is not to diagnose, but to recognize the pattern and respond appropriately. And this is also an important education point. Clients often believe that hallucinogen effects are just completely temporary, but HPPD is one example of how that's not always the case. So understanding this is going to help you provide more accurate information and better support clients who are experiencing these symptoms. So panic reactions, these are often casually referred to as bad trips. And they're one of the most important clinical risks associated with hallucinogens and high-dose cannabis use. While the term bad trip may sound informal or even dismissive, the experience itself can be extremely intense, and in some cases, it can be traumatic for the person. So these reactions are often going to involve overwhelming fear, a sense of losing control, and distorted perceptions that make the environment feel unsafe or unreal. So clients experiencing a panic reaction may believe that they're dying or they're going crazy or they are permanently losing their minds. And these beliefs feel very real in the moment because the substance is altering both their perception and their interpretation. Time distortion can also make the experience feel a lot longer than it actually is, and that's going to increase distress. What may only last a few hours can feel like an endless experience to the person that's going through it. And these reactions are not always predictable. A person may use the same substance multiple times without issue, and then suddenly they have a severe panic response. So factors like the dose, the environment, their mental health status, what is their stress level, and their sleep, that all influences the experience. This unpredictability is part of what makes these substances clinically important. High potency cannabis also triggers panic reactions, especially in people who are sensitive to THC or who already struggle with anxiety. And clients may not expect this, particularly if they think that cannabis is calming. And when the panic happens, it changes how that person is relating to the substance moving forward, sometimes increasing anxiety even when they're not using. So, as a counselor, it's going to be important to take these experiences seriously. Even if the substance has worn off, the emotional impact is still going to remain. And the client may develop a fear of recurrence or increased anxiety or avoidance behaviors. So, your role is to help them to process the experience and understand what happened. And we also need to assess for ongoing symptoms. Minimizing it as just a bad trip can shut down an important clinical exploration. And, clients, they describe cannabis as relaxing, but for a lot of people, especially at higher doses or with higher potency products, it can produce the opposite effect. Anxiety and paranoia are among the most common negative reactions to cannabis use. And these experiences range from mild uneasiness to intense fear, suspicion, or panic. And the clients describe feeling like people are watching them or judging them or talking about them. And they may become overly focused on internal sensations like the heart rate or their breathing. And that escalates their anxiety further. And these experiences can feel very real in the moment, even if the person is recognizing afterwards that they were exaggerated or distorted. And then these high THC products like concentrates and edibles, they're more likely to produce these effects. Edibles in particular can lead to stronger than expected reactions because of delayed onset. So a client may take more and then they think the initial dose is not working, and then they experience this sudden and overwhelming effect later. And that's especially important for clients with pre-existing anxiety and panic disorder or trauma-related symptoms. Cannabis may initially feel like it helps, but over time it worsens baseline anxiety or creates unpredictable reactions. And this can lead to a confusing pattern where the client both relies on cannabis and is negatively affected by it. So as a counselor, we just need to assess for these experiences directly. We want to ask about anxiety during use, not just their overall mood. If a client reports paranoia or panic, that's clinically significant and it should be addressed. And this is just another area where client perception may not match the client reality so clearly, and non-judgmental exploration is going to be key here. So hallucinogens and dissociatives, they significantly impair judgment and perception, and that's going to increase the risk of dangerous behavior. When a person's sense of reality is altered, they may not accurately interpret their environment or the consequences of their actions. And that's going to lead to decisions that they wouldn't make when they were sober. So, for example, maybe a person may misjudge distances or misinterpret objects, or maybe they feel invulnerable. And that's, that's what's going to lead to their physical risk. So they may wander into unsafe environments, or maybe they're going to attempt some risky actions, or they're going to fail to recognize danger. And in some cases, people have been injured because they believed that they could do something that wasn't actually safe or possible. And so dissociatives add just this other layer of concern because that person feels disconnected from their body or their surroundings. And that reduces the awareness of pain or injury, and it increases the likelihood of accidents. And combined with confusion or disorientation, this is going to create a situation where the person is not able to respond appropriately to their environment. And our clients may not always connect these experiences to risk. So they may describe them as unusual or interesting, or maybe it was intense. And they don't really recognize how closely they may have come to harm. So that's why it's important to ask specific questions about behavior during use, not just internal experience. And as a counselor, understanding this risk helps you to assess safety more effectively. And it also helps you educate clients in a way that's grounded in real-world consequences rather than abstract warnings. Impaired perception is not just a psychological issue. It can translate directly into physical danger. And there's a lot of clinical red flags that we need to watch out for when we're working with cannabis or hallucinogen use. Persistent paranoia or anxiety, those are one of the most important. If a client is continuing to experience these symptoms even outside of active use, that's going to suggest a deeper level of impact that's going to need attention. Ongoing perceptual disturbances, like we see in HPPD, that's another major concern. Even if it's intermittent, it affects the person's functioning and it can cause distress. So maybe they're using despite negative experiences, and that's significant. If the client continues to use even after they have panic reactions or paranoia or a distressing experience, that's going to indicate a problematic pattern. And mixing substances is also going to increase risk across the board. Cannabis combined with alcohol and stimulants or hallucinogens, that creates unpredictable effects. And functional decline is another key indicator. If the client's work or relationships or daily functioning are being affected, the use is clinically relevant regardless of how it's described. So as a counselor, red flags are going to help you prioritize. Not every use pattern is going to require the same level of intervention, but these signs indicate increased risk and the need for closer attention. So assessment in this category is going to require specific and intentional questioning. So start by identifying the substance clearly. Is it cannabis, Delta-8? Is it psilocybin mushrooms, LSD, PCP, ketamine, DMT? Is it something else? Each one is going to carry different risks, and vague answers are not enough. And then I want you to ask about frequency and quantity. Occasional use presents differently than daily or high dose use. And then you're going to explore the experience. What does it feel like when they do it? Do they feel relaxed or anxious or detached or overwhelmed? And it's especially important to ask about anxiety, paranoia, or panic, because these are often underreported unless you ask about them directly. Then also you need to ask about any lasting effects. Are there any visual disturbances or increased anxiety or changes in thinking that are persisting after use? Good assessment turns general information into clinically useful understanding, and that's going to help guide your response and improve your treatment plan. All right, this is your opportunity to review some key concepts. So you should be able to explain the endocannabinoid system and how cannabis interacts with it. You should understand the difference between CB1 and CB2 receptors and why that matters. You should also be able to define HPPD and recognize its clinical significance. And you should be able to understand the difference between hallucinogens like LSD and psilocybin and dissociatives like PCP and ketamine. These are the foundational concepts that are going to come up in both practice and exam settings. So you can apply what you learn to a real or hypothetical case. Identify the substance. What's the pattern of use? What are the risks involved? Consider anxiety, perception changes, and functional impact. Then decide how you would respond. What would you assess further? What education would you provide? What referral would be needed? And this exercise is going to help move your knowledge into practice. So the main takeaway from this lesson is that cannabis and hallucinogens should not be underestimated. They affect core areas of functioning like perception and mood and memory and judgment. And while they may be normalized or even celebrated in some contexts, they still carry real risks. And these are going to include anxiety, paranoia, panic reactions, and in some cases, lasting perceptual or psychological effects. And your role as a counselor is to assess accurately and educate clearly and respond appropriately. So just take a moment to reflect on what stood out to you. Consider how this lesson changes your understanding of cannabis and hallucinogens. Think about what you're going to assess differently and what risks you're going to emphasize more clearly with your clients. Reflection is what's going to turn your knowledge into practice. So now you've completed lesson 6 and the full pharmacology foundation of this course. And now you understand how major substance classes are going to affect the brain, behavior, and risk. And this knowledge is meant to support your work as a counselor, not just in theory, but in real client interactions. And now you're better equipped to assess and educate and respond with clarity and confidence. So this completes the core pharmacology content and gives you a strong foundation for clinical application moving forward. Now you're going to take a short quiz. You will need a 70 to pass that quiz. After that, your certificate should pop up. If it doesn't, you may need to go back out and come back in. If you have any difficulty, please feel free to call me at 678-866-5826.